this picture. So this is again, if you see a mass inside the stomach, what are bezoar? Bezoar, of course, are materials which just amalgamate together to form a pseudo mass inside. This is phytobezoar, vegetable. This is lactobazole in baby. This is trichobezoar, usually, particularly seen in young girls. They just pull their hair and keep eating it, and it becomes. This is known as trichobezoar. Finally, rather the second last case, a bit about gastric bending. Gastric bending. So gastric band surgeries, by the way, they are now offered in NHS. Uh, I'm not going to go into it. It's a huge subject, but just one case for your exams, I will show you. Uh, Basic concept of band is that we have got an access port, we have got this access line, and then this is the band. The take home point is now the idea is that they can put in fluid inside to constrict the band or to slightly open it up. The basic idea in gastric band surgery is that this is done for, of course, obesity, morbid obesity. The concept is they create a new stomach. This thing is only about 30 ml, 30 ml. And look at this. Talk about O clocks. If I ask you what is the O clock of this ring, which is this clock? Is it 6, 7, 8? What do you think? 7. And what is this? 1 or 2, right? So this is normal position. Normal position. If it slips down, we call it a slip. And this is where I just teach this one for my students in gastric banding because there can be so many things which can happen. For example, perforations, blah, blah, blah. But this is again the normal gastric band, right? 1 o'clock to 7 o'clock, or maybe 2 o'clock to 8 o'clock, somewhere like that. What do you think is happening here? Slip, right? So this thing is now at about 10 o'clock and this is 4 o'clock, right? This is slip. So this is uh, a slipped gastric band. In emergency, we can pick it up on a CT scan because it's simple, o'clock position. And if it slips down, then the patient will present with obstruction. Just for gastroenterologist, your friend, Mr. D2 diverticulum. D2 diverticulum is a very, very common condition, and we consider it incidentaloma. For gastroenterology, you have to be worried because you can go in your ERCPs, etc. Very, very, very common. D2. On a barium, you can see it. On an MR, you can see it. And on a CT scan, you can see it. There is an entity, we call it intramural hematoma. This happens in trauma cases. It's a unique thing which happens in duodenum. Seat belt type of trauma, patient is sitting here. This is the seat belt trauma here. It will not be very gross. So nothing else on CT scan, not much is happening, but then the patient presents with a lot of pain, etc. Intramural hematomas can happen. So within the wall, it's a unique pathophysiology. So if you see here, this patient presented with this and follow through. On follow through, you can see that contrast goal till D2, but here there is no obstruction. Very unique. There is no obstruction because contrast has gone into the jejunum. But the lumen is this. You see, this is the lumen. It is not causing. So from here to here is a filling defect. Now, what is in that filling defect? In that filling defect is hemorrhage, hematoma. So I just wanted to show you that if you know the pathophysiology, this is a case of intramural hematoma. Okay. Gut, what we call gut, we receive so many of these requests, and at times they end up with you to treat them as gastroenterology. And some of these they end up with IR, as in interventional radiology, but your role is more in upper GI. Now, how do you diagnose it? We diagnose it on radiology, and these are absolute, important questions for your exam. These are asked in your exam. I know it. Uh, how will you protocol these scans? So the patient can come with upper GI bleed, hematemesis, or melena. Key thing is you need multi-phase CT scan. This is the concept, multi-phase CT scan. You have to ask for a non-enhanced CT. Actually, you don't ask. Once you ask, it is our duty as a radiologist to protocol it, right? But you should have a concept that you do a non-enhanced scan. So here comes your pass or fail. Non-enhanced scan plus an arterial phase plus a venous phase. At times we do not do a venous phase, but the first two phases are absolutely critical. Why? Suppose you do an arterial phase and you see something high density inside, right? Now, food can be high density. A tablet can be high density. You are not sure if it is bleed. So you have to have triple phases. You see, this patient has non-enhanced phase. This is arterial. Now on arterial, you can see a blush of contrast here, blush of contrast. Look at the same non-enhanced, and now you are sure it is bleeding. The venous phase will add to your confidence, and at times we don't consider it critical. But the same blood will slightly become more prominent. You see this thing versus this thing, and you will agree that it has moved a bit. But this is not critical, but these two are critical. That you must have a non-enhanced phase. And this is in any vascular imaging. These things should be in your mind. We have got a role of RBC, nuclear medicine, but who can do a nuclear medicine middle of the night? So nobody does it, unless it's a chronic bleed. Chronic bleed is a different subject. And DSA is a digital subtraction angiogram is very what we call invasive. So CT is the gold standard, and you can diagnose it on this. Last case of this session is SMA syndrome. SMA syndrome, some or the other patients, in my experience, they come in seasons, and sometimes you see one, and then for 2 years you might not see a case. Basically, anatomy-wise, what happens is that these patients are usually very, low BMI. So, and with that background, what happens is, if you go back to the anatomy, this is the D2, this is the D3, right? SMA is anteriorly placed. I'll show you. I'll show you. Uh, and because there is no fat, there is a bit of compression on this duodenum. And because of that compression, the patient can come with obstruction-like picture. On a barium examination, this is a classical picture where you will see a band here and you will see some dilatation. This dilatation will not be complete. This obstruction will not be complete. It will be transient. When we do a fluoroscopy, we call it a to and fro movement of barium. We write it in our reports. We will see that barium will come here, barium will go back, come here, go back, and then it goes into the genome, to and fro. So there is in subacute. These patients, some of them are very symptomatic, and some of them end up having surgeries and and gastro jejunostomies, etc. On a CT scan, we have got a criteria. The criteria is that if you see, this is sagittal sequence, this is abdominal aorta, this is SMA. So there is an angle between the SMA and abdominal aorta. If you look here, now this is abdominal aorta. Sorry for those of you who are online, but I am showing to the face-to-face people. This is This is aorta, this is SMA. Now, this is the angle, for example, and the D3 is passing through this, right? Now there is no fat, and it becomes like this. Nutcracker, nutcracker. Now D3 is compressed. Because it is a vessel, it is not causing absolute, but it is causing chronic type of symptoms. So what our practice is that what we do on an axial sequence, we measure the distance between, this is the aorta, this is the SMA, and this is the D3 passing. We measure this distance where I'm pointing out. And this distance, if it is 8 or less than 8, is a CT criteria. So we say it is SMA syndrome. This, and we measure this angle, and if this angle is less than 22, we call it. Usually in my practice, what we do is we do a CT as well as a barium, just to, and then of course they do end up having surgeries. But SMA syndrome is something which you have to know. Thank you very much. 5-minute break. Yeah, 5-minute break, and then we will reconvene. We are slightly off target, so I'll try to make up. But we have got the lunch, so hopefully I will not encroach into lunch, but beware of that.